Today we're going to do it a little differently. This is Damon Haycock, Finance and Research Officer at Silver State Health Insurance Exchange and Nevada Health Link. I'm going to use the microphone here in the room. Hopefully it works, and that way we won't have any background noise for those that are on the phone. Those that are on the phone, we're going to keep you in mute mode until we get through the rest of the presentation, as we have done so for the first 3 sessions. This is session 4 of broker and agent onboarding here at Nevada Health Link. That's kind of a catch-all session. It's picking up the last pieces of information before we do our branding session next week by our communications officer, CJ Bowden. So the session today is going to go over reporting, appeals, and other topics. It's actually a pretty fast presentation, so there'll be a lot of time for questions and answers, and if we get done and get out here a little early, so be it. But the session is supposed to last all the way up until 12:30 if necessary. As I've done every week so far, if you'll please save all your questions to the end. Hopefully throughout this process you will have those answers provided in these sessions. If not, I'll do what I can to answer them. Usually I get stumped by a couple of you, so if that happens and that occurs, we will update our consolidated questions and answers that is out on the website. That consolidated Q&A will be updated today. We sent it over. It'll sync up at noon, so after 12 noon today, the consolidated Q&A will reflect everything up to today, and we'll have those answers hopefully to the questions that were asked in the last sessions, as well as those that have come over through email. We've also posted just a whole ton of stuff on the actual brokers and agents page, and so there is how to be appointed with the exchange, as well as the additional sessions and cheat sheets and all those other things. There's some pretty standard questions I keep receiving, so hopefully that'll answer a lot of them about compensation, how do agencies versus individuals get appointed, or can they? What is the process? So a lot of housekeeping has been going on that website, and we'll continue to use that listserv to send out information so everyone can keep abreast of what's going on. So without further ado, we're going to go ahead and start. On page 2 is our agenda today of the session. We're going to go over briefly over Medicaid and CHIP. Then we're going to talk about tribal clients, reconciliation, reporting, file transfers, individuals, the customer contact center, standalone dental plans, underwriting, and appeals. So briefly, like I said, we're going to go over Medicaid and CHIP. When we do our 4-hour mandatory in-person onboarding session or in-person training for all brokers and agents, we're going to go into this with a little more detail, but we want to give you some exposure today. So Medicaid and CHIP, the ACA has expanded the access to health insurance, of course, through the improvements in Medicaid, and of course the affordable insurance exchanges. Just to give you some insurance status, we had mentioned some figures earlier, but you're looking at about 600,000 uninsured in Nevada and just over 2 million that are insured. That includes not just Medicaid, but all insured individuals in Nevada. So uninsured by the income to poverty ratio, this was also presented at our exchange summit in June, that for those that are 0% to below 100%, we have about 35% of the people who are just over 200,000. For 400% and above, that about 10% of the people, and that's 62,000. And why I mention those first is because the bulk of the state is going to fall within the rest of the insurable categories that work for the exchange or for Medicaid and CHIP. So for 300% to below 400% federal poverty level, there's 40,000 folks roughly. Another 116,000 that are between 200 and 300%. So between 200 and 400, you're looking at about 150,000 people uninsured in Nevada that can qualify for a qualified health plan. So there's your target market for those that don't already have those folks lined up ready for the exchange to open up in October. We can also go down a little bit between 200% and 138%, but the 100 to 200 level is 177,000, or about 30% of the population. Why we show it as 100 to 200, as you'll see on our next slide, we talk about what is the eligibility for Medicaid and CHIP goes up to 200%. That's why this pie chart is set up the way that it is. So on to slide 5, we're going to talk a little bit about the eligibility which is current in today's market, and then what will be in the future starting in January. So there are the children 0 to 5, children 6 to 18, CHIP, pregnant women, parent caretaker, and childless adults. And as you can see, a lot of those have increased. The children 0 to 5 will be increased to 159% of the FPL. Children 6 to 18 go from 100 to that 138% that we've been talking about a lot. CHIP remains at 200%. Pregnant women go from 138 to 159. Parent caretaker go from 22% of the federal poverty level all the way up to 138, so they get a huge increase. And childless adults 19 to 65 who qualify, this is that new Medicaid expansion, so they didn't have any coverage before, now they get all the way up to 138% of the federal poverty level. And why this is important to brokers and agents. And I had a conversation yesterday from a broker up in Lake Tahoe. He asked, I heard you speak earlier at one of your sessions discussing the need to help individuals as a broker or agent enroll in Medicaid and CHIP. And you mentioned that they may end up increasing their income and then come back, and therefore we can get a commission on that sale. And I said, well, I'm not necessarily sure I said that. That sounds like something I would have said. However, I do remember saying that those individuals that you do help may know others who are of a higher income level that you can help you can help that referral process. You help Damon Haycock, who's at 130% of the federal poverty level. I may know somebody who makes a little bit more money than I do, and they're at 200%. And those people get cost sharing reductions, and they get the advanced premium tax credit, and they may have just a very nice, rich benefit plan that they can utilize that they didn't know existed, and now they're coming to you for that help. Additionally, when you enroll a family, you may have an idea in your head that, all right, these people, they say they make about X amount of dollars. I think I have a plan for them. And it turns out that their children qualify for CHIP because they go up to 200% of the federal poverty level. I'm going to assume today, until someone corrects me, that you're still going to try to enroll the adults in a qualified health plan, and you're going to help those children get into CHIP, because you're not going to enroll half the family and tell them, go find a navigator, go find an enrollment assister to do the rest of that enrollment, since it's already doing it for you on the web portal. I'm going to assume that is the process that you all will use, so you can keep that customer service level to those families. So it is important to know the aspects of Medicaid and CHIP when you have those multi-plan families that you're going to have to deal with, or hopefully you want to deal with, so you can get that commission on that qualified health plan. Moving on to tribal clients, American Indians and Alaska Natives. So in order for them to receive the assistance that is built into the Affordable Care Act specifically for that population, they must be a member of a federally recognized tribe. And there's a multitude of federally recognized tribes across the nation. There's a list. CMS has one posted on their site. If you guys want, I can find it and then send it out to everybody. But they will need to initially attest that they are one of those federally recognized tribes. And then through some form of verification, we are going to validate that they are of that tribe. And then they'll either remain within the qualified health plans or within Medicaid or CHIP or even IHS or whatever they're using. They will remain within that process until we can't verify that they are part of that tribe. And there's multiple ways to verify. We can receive on the letterhead of the tribe itself a list of all those members in the service area that are recognized with their tribe. So they don't necessarily have to go and get it individually. The exchange can receive that from that tribe specifically. We've mentioned this before, that there are monthly special enrollment periods. All Native American, Alaskan Indians, or Alaska Natives, American Indians, they can change their qualified health plan once a month. So they basically have a rolling special enrollment period every month if they so choose. That was built into the Affordable Care Act. There are also some cost-sharing benefits. There's no cost-sharing for an American Indian or Alaska Native with income less than or equal to 300% of the federal poverty level, which is about $69,000 for a family of four using this year's federal poverty level table. That new federal poverty level table should be out, we're hoping, next month, early October, and some of these numbers should increase, but we won't know the exact numbers until those come out. So how does that work, no cost sharing? So basically, they have 100% actuarial value. The plan will cover 100% of the costs. And unlike the cost sharing reductions that we went over last time that apply strictly to the silver medal tier, the 300% federal poverty level cost sharing for tribal clients can be used at any tier. So they can actually purchase, say, a cheaper premium and purchase a bronze plan that's supposed to be a 60% actuarial value, and they will have 100% actuarial value. So they have this benefit that no other population has. Again, there's no cost sharing for services provided to an American Indian or Alaska Native by IHS or tribal service units or the urban Indian clinics. So they've also added those through the Affordable Care Act. If those individuals are on a qualified health plan but want to use those services, there's still no cost sharing associated with those. And as I just mentioned, they're eligible to receive services through IHS. If they are, they can also enroll in the exchange. So that's kind of the tribal clients in a nutshell. I don't know how much brokers and agents are going to be dealing with that population, but there's a whole section of it in the Affordable Care Act. There's information that comes out all the time, and we'd be more than willing to share more of what we know about this process. But these are the high points for today's presentation. Moving on to slide 7, reconciliation, reporting, and file transfers. So I've received a lot of questions as to how are we going to send over information for agencies, how are we going to send over information for individual brokers and agents. And so before I get into those specific file transfers in the EDI, let's talk a little bit about reconciliation. So when individuals are enrolled in a qualified health plan through a carrier, one of the 4 now that we all know, we will do reconciliation. It will be done monthly. So we will send over to each carrier. These are all the enrollees that are attached to each plan you have in the exchange. And so what the carrier will then do is receive that document, that 834 file that shows the monthly enrollment, and they will then reconcile it to their system. If there is a discrepancy, they will then come back to the exchange and say, we don't show Damon Haycock on our plan, but you do. So we'll have to go through that process of reconciliation. They may come back and say, we don't show that the NPN number that's attached to Damon Haycock's enrollment is appointed with us. Well, that's not necessarily going to be a bad thing, because navigators, enrollment assisters, and certified application counselors are going to be issued a national producer number for ease in managing the process at the Division of Insurance. So that way they're going to have a national producer number, but they do not have the license of a producer. So please don't spam me with email after this session saying, how on earth, Damon, are you giving these folks this special producer number when they're not producers? This was a decision made by the Division of Insurance to manage the process. So you can look up these folks and see if they're certified, not licensed, certified, active, and in good standing. You can also look up if they've met any of their continuing education requirements. So the system's designed for producers. We are now adding navigators, enrollment assisters, and CACs, so they elected to keep the system simple, at least for the first year. We're also going to reconcile monthly premiums, and then there will be, like I mentioned, that template for discrepancies that these carriers will be able to come back and say, we disagree with X, Y, and Z as part of the reconciliation monthly. As far as qualified health plan reporting, so QHPs have to report to the exchange, have to report to HHS, they have to report to the insurance commissioner, a multitude of different reporting requirements, quality improvement strategies, do they have their provider directories updated? So there's a whole list of them through plan certification. I'm not quite sure how much this is going to affect what you guys do, but recognize that there will be reporting requirements that QHPs will be making, and if they are required to report on brokers or navigators or agents or producers or whatever, they may need to report on the activity that you have performed for them when you've signed up people in a qualified health plan. The types of files we're using, like I mentioned earlier, the 834 enrollment form. We'll be sending over every day that an individual gets enrolled and effectuates payment. That carrier will receive that night an 834 form detailing who that person is, if they had any assistance, what the national producer number is of the person that helped them, as well as are they receiving any advanced premium tax credit, cost sharing reductions, what plan did they select, all of those things. Some of those will be on the 820 premium payment form, so we'll show what was the premium we collected, how much APTC, all these things. I don't believe it will affect the brokers and agents, but you should probably be aware that every night when somebody signs up, that information hits the carrier. We are not holding funds. We are not taking interest on funds. So when someone pays us, we're sending it over. October 1, if Damon Haycock signs up for the exchange and signs up for an Anthem plan, and one of you help me, and I actually pay for it, we're going to send that payment over, even though even though the services don't begin until January. We're going to send it over October 1. So carriers are going to have the funds every night. Then, of course, electronic payment file. One of the requirements of the Affordable Care Act is that you have to allow an individual family member or an employer to pay a carrier directly. That, of course, doesn't really affect most states because that's their billing structure. But with the exception of Nevada and Washington State at this time, I don't know if Rhode Island is still moving forward to perform the individual billing function. But we are going to be collecting billing, or we're going to be collecting the actual premiums. So imagine we're collecting all of those funds every day throughout the month, every month throughout the year, but someone wants to pay a carrier directly. So we had to develop a process so if they paid the carrier, that funding then comes back to the exchange so we can effectuate enrollment and eligibility because we are the system of record. That sums up basically reconciliation, reporting, and file transfers. On slide 8, something for you to keep in the somewhere handy. This is the customer contact center. This is the contact information. So the customer contact center will handle enrollment assistance if you get into a situation where you're having issues with the single streamline application, or if you decide that you need some additional assistance with appeals, general questions, or referrals. Maybe you want to refer them to a navigator or an enrollment assister. The customer contact center can perform that function. There's our telephone number, the fax number, and of course the email address there. Moving on to slide 9. Standalone dental plans. So the Pediatric Dental Essential Health Benefit is part of the 10th essential health benefit that the Affordable Care Act mandates all qualified health plans are supposed to provide. That was the initial Affordable Care Act requirement. Later on, through guidance and through proposed and final rules, they removed that pediatric dental essential health benefit as being required to be purchased. It still has to be required to be offered. Off the exchange, it is required to be purchased and offered. I didn't write the rules. That's how they are until someone shows me something different from CMS. That is the way that it works for on and off the exchange. So we had a board meeting to discuss how we wanted to offer the Pediatric Dental Essential Health Benefit and if we wanted to make it mandatory. And we actually had a committee meeting on our planning committee as well as an actual board meeting where we had a lot of public comment from dental carriers, from the public, from various entities. And our exchange board had decided that, of course, we must offer the Pediatric Essential Dental Health Benefit to everyone as required by the Affordable Care Act. But all children on the exchange now must purchase it. And so that was a decision made by the exchange board to ensure that children have every opportunity to receive the dental care that the board felt was critical, that met the intent of the Affordable Care Act. There are now special market rules for standalone dental plans, and before I get into those, there are 3 ways that the board approved the Pediatric Dental Essential Health Benefit to be offered. The first way is traditional embedding. You can embed it within the plan itself, much like they have the pediatric vision is embedded in all of the qualified health plans on the exchange. The other option is to bundle. We authorize a bundling process. So a standalone dental plan provider can go ahead and develop a product and then bundle that with a qualified health plan to offer one full set of benefits. That plan and the embedded plan all have to meet the market rules for a qualified health plan. So they have to meet the metal tiers, the bronze, silver, gold, and platinum actuarial values. So when they do all of those calculations and they add dental into it, it still needs to come up to those actuarial values of the 60, 70, 80, and 90%. That's for bundled and that's for embedded. For a strictly standalone dental plan that is being offered outside of a qualified health plan, so a qualified health plan that is offered with no dental benefits, an individual will select that plan and then they will be offered the opportunity to purchase a standalone dental plan. If they have children, it won't be optional, they will have to. If they don't have children, it will be optional for them. The standalone dental plan has different market rules as put out by the Affordable Care Act. So instead of having the 60, 70, 80, 90% actuarial value, they came up with a high-level plan and a low-level plan. And the high-level plan is 85% and the low-level plan is 70% for that actuarial value. Additionally, they put an annual limit on cost sharing, an out-of-pocket maximum. What Nevada did to help those dental companies deal with these new market rules is that they provided a safe harbor rule. The dental plans that have submitted standalone dental, or the dental providers that have submitted standalone dental plans to the Division of Insurance, either needed to meet the annual limits on cost sharing as announced by CMS, which was $700 for one child or $1,400 for two or more children, or provide something that was determined reasonable by the Division of Insurance, and that safe harbor rule applies. And the idea behind that was dental plans in today's market traditionally have benefit maximums. So once you get so much benefit cost, then you are on the hook to pay for the rest of it. Benefit maximums were destroyed with the Affordable Care Act. They also had no out-of-pocket maxes. So basically, individuals will receive their initial preventive type of services. They get their cleanings, whatever. But once they start getting cavities or need serious dental work, that they will continue to pay throughout the year. By putting an out-of-pocket maximum and to eliminate benefit maximums means that the risk to the standalone dental plan carriers intensifies. And so the Division of Insurance developed a safe harbor rule to help them figure out what's a little more reasonable as they move into this marketplace. Why standalone dental plans are so important? No qualified health plan that was submitted to the Division of Insurance had dental embedded. So all dental offerings will be standalone dental plans. So we're very happy that we went through the colossal amount of work to make this process effective, because this will be the standard for 2014 at Nevada HealthLink. Wasn't our choice, we didn't ask for it, but they will all be standalone dental plans. I do believe one of the major carriers has their own standalone dental plan, so you might see it'll look like it's part of the actual plan itself. But from what I've been told, and I will be sure to correct myself if I am wrong, what I've been told is that all dental plan offerings will be standalone. We have not seen those come over yet. They're still being approved this week. So a little more on underwriting. There's some major provisions of the Affordable Care Act when it comes to underwriting that makes the new marketplace drastically different than today's. So the Affordable Care Act, of course, eliminated or will eliminate or restrict many carrier rating practices currently prevalent in both individual and the small group market. So there's now a guaranteed issue. The policy is offered to any eligible applicant without regard to health status. Guaranteed availability. Policy must be offered to all eligible individuals. Policy cannot impose a pre-existing condition exclusion. I'm sure you've all heard pre-existing condition exclusions are now gone. I'm just trying to emphasize it yet again. Guaranteed renewability. Policy is renewed to any eligible applicant without regard to health status. And then premiums, age banding, and tobacco use. Age banding has been reduced. That for premiums may only vary from one individual to the next based on age. So it's a 3-to-1 age banding. What you charge a 20-year-old, you can't charge more than 3 times to a 60-year-old. Tobacco use is 1.5 times to 1. So what you charge if you charge a 20-year-old $100 premium and you use tobacco, you can impose a 50% increase on that and charge them $150. Recognize that tobacco use addition does not covered by any subsidies. No advanced premium tax credit, cost sharing reductions. You're stuck paying for that entire amount. And Nevada is allowing carriers to age band tobacco use. So much like they age band the regular qualified health plan, the $100 versus the $300 20-year-old, 60-year-old numbers, then they may do it, and I haven't seen them yet, but they have the ability to age band that tobacco surcharge as well. Moving right along to appeals. So for individual appeals, they can appeal a whole slew of things, as you see on slide 11 here. The advanced premium tax credits, cost sharing reductions, the Medicaid or CHIP pre-qualification, their exemptions from that individual mandate that we discussed a few weeks ago, the affordable minimum essential coverage, Social security number, validation, lawful presence, incarceration, residency, tribal affiliation, catastrophic or transition plan eligibility. All those you can sum up into eligibility. They're going to appeal their eligibility. They apply through the Nevada Health Link, through the single streamline application. They say they want help with paying for health insurance. We come back and tell them this is what you are eligible for. They disagree with it. They want to appeal. Continuing on, for employer appeals, the shop employer eligibility may appeal for participation or contribution rate or residency, or if they have, most of the time I'm going to assume it's going to be for participation. They're going to submit a roster of all full-time employees for their company, and they're going to say, I have 12. And so we tell them you need to have 75% of that to participate, and we only get 5 people that participate. And they say, well, I want to appeal that because 6 of them either had minimum essential coverage or were on another person's plan, or they're no longer with the company now. And so there's going to be those types of things that will happen. And then, of course, for the employer that isn't on the shop exchange, if they want to appeal the affordable minimum essential coverage. So as we mentioned before, an employee from an employer here in Nevada wants to receive a subsidy and doesn't want to pay the cost of the health insurance from their employer. So they elect not to take that. They come into the exchange. We go through the process. They don't tell us who they work for. They say they're not employed, or they give us an address that isn't accurate. And we send out that information to the employer and say, look, this person is going to get a subsidy. You may be liable for a tax penalty. And then they end up, well, they would have been, of course, that got pushed to 2015, but we'll talk 2015 now. They receive that tax benefit, and then that employer comes back at the end of the year and says, I just got dinged for a tax penalty, and I want to appeal that my employee says I didn't offer affordable minimum essential coverage, and I want to appeal that. So that's an appealable reason. And then, of course, the things that cross both sides of the exchange, both for individuals and employer appeals. There's the life event, dependent eligibility, terminations, the timely notice of processing, system issues. A good one to keep in mind, broker, agent, or exchange enrollment facilitator misconduct. We don't want to see any of those with anyone's name from any of these sessions on an appeal. Or other the catch-all. So let's talk about that appeal process. Hopefully you don't have to deal too much with that, but I know all brokers and agents like to provide that utmost highest customer service. And so when they say, gosh, I really don't like what happened, I want to appeal, we want you to know how this process works. So who can appeal? In the individual marketplace, only the applicant, the enrollee, custodial parent, or their authorized representative can file that appeal. In the shop, the employer can file an appeal on behalf of themselves or one of their employees. Non-shop employers can file an appeal on behalf of their organization. So what is the process to appeal? So when they want to appeal a decision, that entity, the best thing to do is have the entity contact the customer contact center. The customer contact center is going to act like a triage. So they're going to receive this information, and the individual or employer is going to contact the customer contact center and say, I have a problem with X. I want to appeal this. And the idea of triaging it through the customer contact center is there's going to be certain situations that they're going to want to appeal that really aren't appealable decisions. And I'm gonna pick on one that's really silly, but I had issues with reading the text on the single streamline application. The font was too light, the website was hard to read for me, and I want to appeal because I couldn't enroll in health insurance. So there's certain things that are not appealable. There's certain things that are appealable. And so the best thing to do is direct them to that customer contact center that I showed a few slides back, and they will help determine what the next steps are for this individual or employer. What I'm going to do, though, before I go to the Q&A, I'm going to back up. I'm going to briefly, I know we're at a half hour now, but I'm going to briefly go over the appeals process so you have just a general idea of how it will work. So there are two processes that can occur, and they can even occur simultaneously. If someone wants to appeal their eligibility or enrollment with the exchange, specifically to a qualified health plan or an exchange-controlled situation, as one of those bullets from an earlier slide, they will then contact the customer contact center, and they say they want to appeal. So hopefully, and actually, before I continue, let me back up. When an individual or family member on the individual exchange signs up for health insurance and they request, they're going to attest that they have certain family size, they have a certain income. We're going to bounce that information off the eligibility engine, which bounces off the federal hub. If it comes back different, significantly different, we are going to come back to that person and say, no problem, we're going to enroll you in a qualified health plan based on your tested information. However, you have 90 days to provide us with information that justifies what you have put in here. If after 90 days you don't provide it to us, or you provide us which we feel is inadequate, we are going to reverse the decision back to what the federal hub and the eligibility engine said, and that is what you're going to have to live with. And so in those 90 days, imagine this, that individual either sent information that wasn't acceptable or did not send information. So we redetermine that individual. That person says, nope, I disagree with this. I want to formally appeal. They will then file a formal appeal. If it has only exchange issues with it, our exchange appeals team will look at that appeal and do an informal resolution process to try to avoid a hearing and to get this person, redetermined if necessary, as soon as possible. That situation can take up to 30 days. They will deal with our internal exchange appeals team. If after those 30 days or within the first 5 days or whatever, if it turns out that we can solve the problem and it does make the situation better for the individual, we'll redetermine them or return them back to what they originally had, and then they're going to be able to move forward and be successful. If the decision is still upheld that we needed to redetermine the person, that they didn't provide the right information, and we disagree with whatever they had tested, then they can request a formal hearing. All hearings will be held by the hearing officers at the Division of Welfare and Supportive Services, the same hearing officers that hear appeals for Medicaid and CHIP. Now I'm going to pause there and go back to the beginning. So for an individual that then applies through the single stream application and they want to apply for Medicaid, and it comes back and says, it appears you are not eligible for Medicaid, and they say, well, I want to appeal it. If it has anything to do with Medicaid or CHIP, it's going to go directly to the Division of Welfare and Supportive Services. Their appeals team is going to go through their informal process, and then we'll go through their hearing process, and then they will render a decision. So the tricky one is they're appealing that they did not get Medicaid, and they're appealing that they got incorrect advanced premium tax credit or cost sharing reductions or whatever. Because that affects both different areas, the CMS and the feds have decided they don't want to see two different appeals processes because it takes a lot of time. And so what we've elected to do, what CMS has allowed states to do, is allowed Medicaid to delegate Medicaid appeals to the exchange, so that the exchange can just be the one-stop shop. We thought, well, who's probably better at these appeals? An exchange that's a new entity or the entity that already deals with appeals today? So we did a reverse, and we said, we're going to delegate our exchange appeals to the Medicaid appeals entity, and since they're already used to going over adjusted gross income and validating all the things that they do for their insurance plan, we're just going to train them, and then they can handle all of our appeals that are double. So that appeal then that has both, let's say, an APTC eligibility and a Medicaid eligibility will go right over to Welfare and Supportive Services to their team to start working that appeal. As it gets to a hearing, it all coalesces back together, and a hearing decision needs to be made within 90 days of an appeal request. So the exchange has to render on exchange appealable decision within 90 days. Once that occurs, if the individual still has an issue with what was decided upon, if it's an exchange issue, they get to appeal one more time to HHS, to the Federal Health and Human Services. If it's a Medicaid issue only, they get to appeal to district court. So as you can see, this process can be pretty convoluted, and we actually have we have it basically written out on our carrier onboarding page because we wanted carriers to understand how this process worked for appeals. And you'll see that if everybody uses every last second of time that they have available before they have to render decisions and request appeals, because they can wait so many days before they can request an appeal, when you add it all up, I think the total is somewhere around 400 plus days to render a final decision on an appeal. So that's not, of course, the goal. No one wants to get to 400 days, but if everyone uses every last second of time available to them, both the appellant and the agency that's handling the appeals, it can take over a year. So as you can see from this quick, brief discussion about appeals, nobody wants appeals. We want to do the right thing the first time by these individuals, and we want these decisions to be appropriate and effective, and we want them to be defendable. So with that, I think we are done with the presentation for today, and we can go to questions and answers. Do you want to take one in the room, or do you want to? How do you want to start, Athena? We'll go in the room. So let's take one here in the room first.
I have two questions, but they're easy. I was wondering if ortho is included in the unlimited dental and the max cost sharing.
I'll find out, but I think medically necessary or ortho is.
Okay.
I'm not sure about the cosmetic side of it.
Okay.
That question, as far as what is authorized in those things, should probably go to the Division of Insurance, as they're the ones that are approving those plans to be sold on the exchange.
Okay. And then just wondered if the one family member uses tobacco, is it going to apply to all family members on the tobacco rate, or is it just for that member only?
So the tobacco rate is supposed to be, everything's supposed to be individually rated. Everything in the exchange is individually rated. So hopefully that I'll just leave it at that.
Yeah,
Let's take one on the phone.
To place all participants in talk mode, press 1. To begin a question, your conference is now in question and answer mode. To summon each question, press 1, then 0. Each question will be asked in the order it was received. You have 0 questions remaining.
Okay, before I go back to the room, just so everyone knows, and I said this at the beginning for anyone who joined late, the Medicaid CHIP part of this presentation, we went over very briefly. It'll be part of that 4-hour in-person mandatory training to be appointed with the exchange. And so we will go into it in a little more depth so people will understand what their roles are and how to assist those individuals and families enroll in that service. Because I promise you it will come up, and it's up to you how you're going to handle that process when it comes to your door. Let's take one in the back.
Yeah, on the pediatric dental plan, it says must be offered to anyone. That's even people without children?
Correct. And so we have to offer all 10 essential health benefits.
Okay.
And that's an Affordable Care Act requirement.
So somebody on Medicare could buy this?
So here's the thing, and you know what, thank you for asking that, because it is obviously not as clear as I was hoping to make it. In order to sign up for a standalone dental plan, you must first sign up for a qualified health plan.
Okay.
So to answer your question about a Medicare individual wanting to purchase a dental plan, they'd have to first purchase a qualified health plan, and then they would move on to the next screen that would offer them the ability to purchase a standalone dental plan. The standalone dental plans are meant to be in conjunction with a qualified health plan, not as a supplemental product to be sold on its own. Even though it's called standalone, and I understand the semantics of it, the exchange was not afforded the authority to offer supplemental products through the legislature. That was in our bill that did not get passed. We were looking to do adult vision because there's no provisions for adult vision. And we were looking to be able to do other forms of health insurance, but that was not approved by the legislature, and so there will be no supplemental products. Try one on the phone, Athena.
You have 3 questions remaining.
Hi, I would like if someone could please elaborate on the payment process. I was a little bit confused about payments coming in at the carrier level and then being routed to the exchange, or will payments be routed to the exchange at all?
So I'll walk through both processes of payments, the preferred method and then the method that we will allow through the Affordable Care Act because we have to. So when a family, we'll use a family as an example. A family is going to enroll in a qualified health plan. In order to effectuate that first month's coverage and payment, they have to make payment to the exchange. The exchange will accept payment in a multitude of ways. Through our web portal, through our call-in service. People can even go onto their bank and set up automatic payments that'll mail out checks. If people want to pay by cash, those unbanked people that are out there in Nevada that need to make those payments, they can go to one of any, I think there's 200 or 300 MoneyGram locations statewide where they can pay cash to MoneyGram, and MoneyGram will then send payment to the exchange. The exchange will receive the payments. The exchange will then, through our contractors, will reduce those premium payments by our per member per month fee, and our contractor will then remit payment to the exchange for our per member per month fee, and the carrier for the remainder of that premium. And that will happen on a nightly basis as payments get made. The Affordable Care Act requires the ability to pay, for individuals to pay a carrier directly. So we're gonna use some round numbers just to illustrate this. So if it's $100 premium payment, we'll say our per member per month fee is $5. We get the $100. We take $5 off. Our contractor that is handling our payment processes will remit to the exchange the $5 per member per month fee and the $95 to the carrier. If that family or individual wants to pay the carrier directly, they send a $100 check or they pay however the carrier accepts payment to that carrier. That carrier then needs to send the full $100 back to the exchange, so that way we can show that they are current. We will then turn right back around, take the $5 off per member per month, and send back the $95. It is a pain, and so we are hoping that doesn't occur very often, because as we are the system of record, in order for us to ensure that somebody is enrolled, we have to see that they have paid. And so we are, as the system of record, will send out enrollment information, not vice versa. So as a carrier says, well, we've enrolled so-and-so in our plan, that you haven't until the exchange has enrolled you in the plan. These are exchange qualified health plans. That was the decision made well over a year ago on if we were going to do individual billing or not. So that is the process in place today. Through our carrier onboarding, it appeared many of the carriers that were considering participating were going to disallow payments directly to them because of this process. But we have to allow them to make those payments. The Affordable Care Act does not require carriers to accept them. Hope that answers your question. Let's take one in the room.
Yes, back to the appeals process. One of the participants in the appeal process shows as authorized representative. Is that also a broker?
So yes, a broker can be named as an authorized representative for the exchange. And so you can file an appeal on behalf of your client. I would leave that up to your discretion if that's something that you wish to partake in.
Thank you.
Let's take one on the phone.
You have 2 questions remaining.
Hi, I have a question in regards to commission. If we were to purchase our own, as producers, if we purchase our own insurance, will we be paid commission on that?
So if you let me see if I understand this question correctly. If you as a producer need your own health insurance and you get on the exchange and sign yourself up, can you attach your national producer number and send over to the carrier that you are appointed with or have an agreement with to receive a commission? Here's what the exchange will do. If you sign yourself up and you put your NPN number on there, we'll send it over to the carrier. It is up to the carrier if the carrier is going to pay you a commission. The exchange is not in the commission game. We are not part of that process. We have no desire to micromanage or influence the commission process for brokers and agents or producers with their carriers. So we will we will simply transmit over your number.
Okay. I have one more question. A lot of the audio has been kind of off, and I know that you also record it for us to be able to listen in on it at a later time. Do you know if it'll probably be a bit clearer?
I believe so. So I believe so. I've checked the YouTube site and I can hear my voice, which always sounds awkward, when you hear your own voice on the recording. But I can hear it pretty easily through my computer. So with the exception of last week where we ran into a technical difficulty during the presentation part, we did capture the QA. After this meeting, later this afternoon, I will send out, or later this afternoon, or at worst case tomorrow morning, I will send out something on the broker and agent listserv that points directly to this presentation. And what I'll do is I'll even point to the site itself that shows all of them. And so if you want to go back and review, you'll be able to hopefully hear everything that was said in this room, as well as what was said over the phone and the questions and answers.
Thank you.
Let's take one from the room. I saw your hand up earlier.
Sorry. So with regard to Medicaid and CHIP, so if because of the 200% now for the children, are we still going to be able to enroll the children in CHIPs if the parents have an employer plan available to them?
So that'll depend if if the employer offers coverage for their dependents.
If they do, they would not be eligible.
It's
for
my
CHIP.
understanding that CHIP, and this would, I can ask CHIP, I can ask the CHIP agency. It's my understanding that if you receive minimum essential coverage somewhere, an offer of minimum essential coverage somewhere else, you do not qualify for that assistance. It's the intent of the program is to provide insurance to those that can't get it or can't afford it. If it's offered to an employee, I believe if their children is offered minimum essential coverage, that they cannot turn around and roll them into CHIP, but I'll find out. Let's take one on the phone.
You have 2 questions remaining.
Yes, I'd just like to know, or maybe someone else also had the same question. When you're giving an example about how the kids can go on CHIP and the parents can go on the exchange, how is that done?
Not a problem. So when a family is navigating through the single streamline application, or for intents and purposes of this session, you wonderful brokers and agents are assisting that family navigate through the single streamline application. One of the questions will be, after the demographic information is entered, do you want help paying for health insurance? And that is where you want to check the box and say, yes, we do. And then we will send over all that tested information to our eligibility engine. We'll bounce off the federal hub, come back and say, this is what you are eligible for. You appear to be eligible for Medicaid or CHIP. You are eligible for APTC at this level. You are available for cost sharing reductions. We will let that family know this is what you're eligible for. Then if they want to continue with the process of enrolling in Medicaid and CHIP, they will be asked, do you want to enroll in these public assistance programs or apply? They will say yes, and then they will all the information will be sent back over to them, and they will be able to, based on their tested information, if they appear to be eligible, will be able to go through what we'll call pre-eligibility or pre-enrollment with public assistance through Medicaid or CHIP. At the end of the process, these CHIP plans will show up during Shop and Compare. Maybe that's probably the easiest way to answer the question. How will they enroll in CHIP? So there'll be different tabs for each member of the family. So we'll say the father, mother, and 2 kids. And so the father will show up, these are the qualified health plans you qualify for. The mother, these are the qualified health plans or Medicaid that you qualify for. This is for the children, these are the qualified health plans or CHIP plans that you qualify for. And they'll be able to shop and compare and select those plans. Once they select a CHIP plan, we will go ahead and at the end, they will effectuate payment for their qualified health plan, and the application will be sent over to CHIP, and CHIP will then issue a final determination of enrollment. And so within so many days, that family will receive their ID cards, their medical cards, not only for their qualified health plan from that side, from the commercial market, but they'll also get a packet from CHIP saying this is your benefits, this is when you can start using them, this is how you go ahead and pay for them, and then we'll have to collect payment at that time and that's what we're still working on, collecting payment for CHIP. But that is the process. Hopefully that makes sense. If not, I can clarify it further.
One more question again. So, with them doing that, then they would say the parents have to go on exchange, and the 2 kids qualify for the CHIP.
So yes, I want to make sure we state it appropriately. Semantics are kind of a killer in this business. So they don't have to do anything. There's no have to. What will happen is that they'll say that the children appear to be eligible for CHIP. And so if the family wants to enroll the children in a qualified health plan, they will not get the subsidy for those children because the children have been offered minimum essential coverage through another approved health plan.
Is there a link that I can go to learn more about this?
So what I was hoping to have happen, and it doesn't look like it will, is I wanted to actually do a demo for everybody. But when you sign up for your 4-hour mandatory in-person training as a broker and agent to be appointed with the exchange, we are going to go over the single streamline application, and we're going to illustrate a qualified health plan and a CHIP enrollment so you can see how this process will work. You are always more than welcome to contact the Division of Healthcare Finance and Policy, which oversees Medicaid and CHIP, and ask one of their program managers or program leads to discuss how the process is for enrolling in those programs specifically. But at this time, outside of the way I've just illustrated it to you, I'm not quite sure we have another link that shows this process. We have other presentations. If you look on our website and go where we had our Exchange Summit, there was a Medicaid and CHIP presentation put on by the Division of Healthcare Finance and Policy, which was really good. It explained a lot of the processes for enrolling in CHIP, and you are more than welcome to look at that as well.
Thank you.
Let's take one in the room, sir.
Yes, back on the pediatric dental essential health benefit, 2 questions. One is, my understanding is with the $700 max out of pocket basically for one child, and whether it's paid at 85% where the insured member will pay 15%, or on the low level plan, the insured member is paying 30%, they have a max out of pocket of $700. Is there a pre-existing condition, to your knowledge, will there be a pre-existing condition to the dental? And is any part of that benefit influenced by a PPO network on the dental side?
So let me see if I can answer each of those. First of all, there is no such thing as pre-existing condition exclusions in the Affordable Care Act. That applies to every plan, both standalone dental, qualified health plans. They cannot rate off of pre-existing conditions. Secondly, the $700 individual out-of-pocket maximum may not be what is actually the out-of-pocket maximum that you see at Shop and Compare, because the Division of Insurance has that safe harbor rule, and I gave you those examples as to why that may not be an affordable option or opportunity for individuals to enroll their children in standalone dental plans. They may, if they have to stick to the $700, $1,400 out-of-pocket maximum year one, they may not be able. That plan may be too expensive for anyone to purchase. And so what we have to wait to see what the standalone dental plans actually look like before I can confirm that $700 out-of-pocket maximum. As far as PPO networks, it's my understanding that every plan that has been submitted that I haven't seen yet, so give me an opportunity to take that back, are all HMO plans. And so discussing PPO networks, I'm not certain I can actually answer that question for you today.
Thank you.
Is someone on the phone?
You have one question remaining.
I have a question about Medicaid eligibility. If you have someone who is projecting their income because they're 1099 or they're self-employed, and they're right at the cusp of the 138%, and they do not want Medicaid, they'd rather get the APTC credits, can they do that?
So the answer is, if they truly are eligible for Medicaid and they elect not to enroll in Medicaid because they are turning down that minimum essential coverage, they are not eligible for the advanced premium tax credit.
What happens if it's close and they're projecting their income to be over, say, at 140%, and they spend the year and they get the APTC credits, and after the year it finds out that they would have been Medicaid eligible?
So what would happen in that case, as far as I know now, please recognize my crystal ball is a little foggy. I can't always see into the future as well as I would like. But if an individual attests that their income is at 142% of the federal poverty level, they will be eligible for the advanced premium tax credit as long as they meet eligibility for the exchange as a whole. They will enroll in that qualified health plan. They will receive that advanced premium tax credit all year long. At the end of the year, they will submit their income, and with their income, they will, if their income fell short, it appears, I love that word appears because it saves me, it appears that they will then receive a refund from the additional APTC they were supposed to have received. I don't know if the IRS is going to say you should have been on Medicaid, and therefore you need to pay back all that APTC. I can't imagine that happening with the amount of leeway that the federal government has been providing in the last month for employers, for other mandates. But if someone projects that they're going to make more money and they did not receive Medicaid, I don't think they're going to have to pay that back. However, if they say that they're going to be at 137% of the federal poverty level, and it comes back and says it appears you qualify for Medicaid, would you like to enroll Medicaid? And they say no, then they're turning down that coverage.
Okay, and then I have one other question about children, because they're all HMO products, and you can have a child up to the age of 26 on your policy, and if they go away to school, say Oregon, because I got this question this week, how do they do coverage when someone's out of state?
So there's two options that we know of that maybe there's three options. So first of all, that the child can still, the 22-year-old can still enroll in the family's plan, and then their network is within the state of Nevada, and so you're looking at out-of-network costs. Nobody wants that, so I'm not going to say that's a real viable option. The second thing they can do is they can enroll in one of the two multi-state plans that'll be on the exchange, and we're waiting to get those finalized through the Office of Personnel Management, and we're hoping that the networks will be multi-state, so that may work for that process or that program. Thirdly, I would probably recommend that individual enroll in a child-only plan or in an individual plan in the state in which they're residing in at the time when they're in school. So if they're going away to Oklahoma and they want to receive medical coverage in Oklahoma, then they can always state that they live in Oklahoma for the 3-4 years, however many years they're in school, and that they can go ahead and be enrolled in a qualified health plan on the individual market over there.
Are the multi-state ones that you're talking about still to be with the same 4 carriers?
So 2 carriers are going to be announced for the multi-state plans for Nevada. We're just waiting for the plans so we can see them, and then that information should be coming out shortly. They are 2 of the 4 carriers that already exist.
Okay, thank you.
Any question here?
For someone that 65 or better that doesn't have a sufficient number of quarters paid into Medicare, will they be allowed to go on the exchange and get any of the premium subsidies?
So, and this one always stumps me, and that's a good question. They can always go on the exchange. They can always go on the exchange. If they are not offered that minimum essential coverage because they don't qualify for Medicare, I have to, let me research that again. The last I was told is that that people over 65 can't receive subsidies on the exchange. But I want to confirm that because it contradicts the minimum essential coverage language that's everywhere else in the Affordable Care Act. So I will find out about the over 65, not enough quarters for Medicare, and then I'll update the consolidated Q&A with that within the week.
Because I have had cases where a client will have a family member usually moved here from another country, they've never paid into Medicare, they can buy into Medicare, but it's fairly expensive.
So yeah, let me double check and I'll post that answer and send that out. Sorry to cop out.
You have 0 questions remaining.
Any more in the room? All right, so we've hit right at noon, and if we don't have any more questions, I'm going to go ahead and end this session here today. Please recognize that next week is extremely important for those that want to start using our Nevada HealthLink logo and brand standards. I'm not going to personally name the specific broker or agency that has already violated that brand standards guide, but please, please, please don't put movies out on YouTube. Don't start putting the Nevada HealthLink logo on your card. Only those folks that are going to be appointed and have received an appointment with the exchange are going to be allowed to use our brand and to reference the Nevada HealthLink in their marketing and advertising. So please don't go outside, take a picture of our logo, print it up on a magnet, throw it on the side of your car door and say, I'm a broker or agent for Nevada HealthLink. You will get a call from our communications officer and potentially the Division of Insurance. So with that in mind, we hope to see you here next week. Our communications officer will be providing that brand standards presentation. It's basically just the brand standards guide. He's going to go over it. I will post it as the presentation for session 5, but it's already out there on our website anyway. And we will post this up to YouTube hopefully later today. And then I will address the few questions on the consolidated Q&A. Thank you everybody for coming.
Thank you.